Hi, everybody. I'm back. So I hope you had a good 2 weeks with guest lecturers from Kyle and Valeria and everybody else. So today I'm going to pick up now with the final two sections of the class. The first one will be on depression and bipolar disorder. And then the last week of the class will be about schizophrenia and, of course, all the pharmacological drug-related treatments to both of those disorders. All right, moving ahead. Okay, some announcements. Yeah, like I just said, this week we'll focus on depression, antidepressants, but also bipolar. And next week we'll get into schizophrenia. I just mentioned it with the email, but there is an extra credit quiz coming up. It's on D2L, or will be on D2L. You can take it anytime between the 4th and the 5th of May. There'll be 30 questions, and you'll have an hour. Should be fine. It's open book. And so if you do well on it, if you get an A, you get 3 points. Get a B, you get 2 points. If you get a C, you get 1 point, and they'll all count towards your final grade. All right, we'll have a review on the 5th of May. It'll be like the last one, where we'll just have it as an open Zoom. I'll have some PowerPoints prepared, but of course you guys are always welcome to fire any questions my way as well. I'll record that Zoom review session as well. And anytime, please send me questions or emails through emails or whatever, and I'll definitely try to address them. And if there's a general interest and people want to meet and have like a virtual office hours, even with a group on Zoom, let me know. I'm happy to do that. All right. The exam, we're still going to stick to the official university schedule, so it's at this obscenely early time in the morning at 8 a.m. on the 12th. So yeah, 5/12, May 12th, 8 a.m. It'll be the same exact situation as the other exams, same number of questions effectively, same amount of time. So yeah, so get ready for that. And I guess those are the announcements. All right. So yes, I got to pick up on a rather bummer of a topic because that's depression. So if you've started going into the book, into the Julian book, it's really actually they do a nice job of covering both depression, the kind of from the societal level down to the pharmacological level. But it also has a lot of details that you might find somewhat overwhelming. They really go to town in that chapter, at least towards the end, on all the very specific medications. Like, okay, I can't even pronounce it. Well, I can't pronounce a lot of stuff, but I can't pronounce levomilnacipran or desvelnifaxine. Okay, so, but I can't pronounce it, so it probably means you don't need to memorize it. Okay, so once it gets in that section of the text where they're going to the very specific antidepressant drugs, I'm not going to expect you to memorize them. If the drug is mentioned specifically in the lectures, yeah, then you should pay attention. But there are a lot of extra details as you'll find in that. If you're very interested in depression and its treatment, I would pay close attention to that section of the chapter. There's a lot of really interesting information. And also, I found really interesting, they have a section near the end called complementary and alternative medicine approaches, basically where different supplements like vitamin B, omega-3s, St. John's wort, how when used in conjunction with other treatments might be helpful and might actually improve the effectiveness of other more standard treatments. So there's some interesting stuff in there. I'm not sure I'll have time to get to that officially in the lectures, but it's worth a read. All right. There's also some interesting things in the chapter I don't know if I'll get to on the gut biome, the microbiome, and how that might play a role in depression too. So yeah, just interesting things in the reading that I may not get to because there's more than enough to talk about with regard to just the diagnosis and the neural mechanisms thought to be involved in the standard treatments of depression. Okay, affective disorders is the general topic for these next two lectures because it includes two of the most common general categories of affective disorders or mood disorders, one being depressive disorders and the other being bipolar disorders. And these are disorders that really affect how you feel, just the general level your mood is at. And so the general goals for today are to really understand what the clinical features are of the major disorders in the affective disorders group. What are the risk factors for major depressive disorder? We'll focus mostly on major depressive disorder today. How stress plays a role in depression, and how depression impacts the hippocampus, and how the hippocampus can impact depression in the context of the HPA axis, which you've heard about from way back in like the first couple weeks of the class. And then we'll finish up with a discussion of the genetic and epigenetic studies that connect with depression. Like how much do your genes, or do epigenetic modifications of your genes contribute to depression? And then in the next class, I'll focus a little bit on bipolar, but mostly I'll focus on the brain mechanisms and the pharmacological treatments of depression. All right, so moving forward, what are affective disorders? The golden standard that we use as psychologists is this DSM-5 book that essentially gives you a recipe on how to diagnose different affective disorders and classify them. All right, so these mood disorders, like I was mentioning before, come in two general categories. The first is depressive disorders, which covers things like major depressive disorder. You might have also heard of seasonal affective disorder. Maybe we don't get that as much in Arizona, but I surely remember feeling that a bit in Wisconsin when I grew up there. Premenstrual dystrophic disorder and persistent depressive disorders. That's like when you have depression, but it's lasting 2 or more years. So those are some general types of depressive disorders. Then you have bipolar disorder, which has depression as one component, but as a second component, it also has almost the opposite of depression, mania. And there are different types of mania associated with bipolar. And that somewhat determines which of two types of bipolar disorder a person might have, bipolar 1 or bipolar 2. And I'll talk about those two subclasses of bipolar disorder when I get to it. All right. So what are the psychological symptoms of depression and mania? One of the first symptoms of depression generally, and we'll talk about the DSM-5 categories in a moment, but generally, it's just this loss of interest in just about everything and an inability to experience pleasure, which is called anhedonia. There's usually a sense of hopelessness, sadness, worthlessness, and guilt and desperation. And it's not necessarily connected to any event. It's generalized and not specific. It just can't be, your finger can't be put on it. Thoughts of suicide are common, although, again, suicide is relatively rare in the general population, but it is definitely more common in depressed individuals. So in one estimate, there's this idea that people who are depressed, about 7 to 15% of people who are depressed have thoughts, at least, of suicide. In the general population, only 1 to 1.5% of the population actually have these thoughts or suicidal ideations where you think about suicide. So it's common, more common in depression. Now, mania is a different animal altogether. The primary symptom of mania, at least for most classes of mania, is this elation. You like really feel on top of the world. You have little need for sleep. You have hyper confidence. You might make impulsive decisions, spend all your money in a big investment, that type of thing. And the main key on bipolar disorder is that you then start alternating between these states of depression and mania. All right, moving on to comorbidity, just a more of an interesting aside, is that depression is one of the most common disorders that happens to be comorbid with other disorders. That meaning that if you have anxiety disorder, there's a much higher chance that you'll also have some depressive disorder. If you have chronic pain, if you have Parkinson's disease, if you have Alzheimer's disease, as we talked about in the last lectures on Alzheimer's disease, is that there's a massive undiagnosed population of dementia patients that don't get diagnosed when they should with depression. Alcohol dependence also has a high comorbidity with depression. So comorbidity just means that one disorder is tied with or linked to or correlated with another. Also, as an aside here, which will come up in a bit too, is that when we're talking about depression itself, depression usually lasts around 6 to 9 months. So if you're feeling depressed, but it kind of comes and goes in a couple days or a week, that's not clinical depression. Depression usually lasts at least 2 weeks, and then it can last 6 to 9 months, and then it will fade away. But there are these other special classes of depression too that can last even longer than that. All right, depressive disorders, and we'll focus on one subclass of depressive disorders called major depressive disorder, or MDD. Before going into that, let's talk about a little bit of the history and at least one historical figure that very likely had major depressive disorder, and that is our friend Abraham Lincoln. So some quotes from some of his colleagues and friends. One said, his melancholy dripped from him as he walked. Another colleague of his said, no element of Mr. Lincoln's character was so marked, obvious, and ingrained as his mysterious and profound melancholy. So Abraham Lincoln was a depressed guy, and it was a relatively permanent feature of his personality. At least it followed him throughout his life, where he'd have bouts of depression. He was a gloomy person. He wept in public. I don't know why they mentioned it, but he recited maudlin poetry, which is like really sappy really sappy poems about happy orphans and things like that. But anyway, I think that he did that to put himself in a good mood, like he needed jokes, he mentioned, for survival. He remained in bed during his wedding. He had suicidal ideation when he was young. But even so, he went through quite a lot, not only through the Civil War, but just dealing with his own mental demons and depression. But what's just utterly amazing is, despite having to go through all of that, he pushed through and he accomplished amazing things. But it just says too that depression can impact anyone. I don't care like what your status or level of authority or income is. It happens to everybody. It can be utterly debilitating, but in Lincoln's case especially, not incapacitating, even though he had these situations throughout his life. He could keep moving forward and helped our country get out of a period of great darkness. So it does give us some hope. And he also, somewhat to his melancholy, attributed some benefits to it. And actually, some of the science bears this first one out, is that people with depression often make more realistic decisions, in the sense that they avoid the kind of delusions you might get if you're overly optimistic. They see the bad with the good perhaps a little more fairly than the average person in many ways. There are also well, at least in Lincoln's case, he felt that his melancholy, which at the time we would probably call depression, felt it gave him some insight and dignity and courage. So that was Lincoln's kind of situation. All right, now going back to the present day, what is depression like in our society? So it's common. So about 1 in 6 of us throughout our lives, that means in the class around 200 students like this class, about 32 of you, including me, will have a good chance of having depression at some point in your lifetime. That's a huge number. 16% of the population will have that. I mean, as in a clinically diagnosable level of depression, not a period of sadness or grief, but true depression. Currently, at any given year, at least around 16 million Americans suffer with depression. And the risks of depression are higher in women than men, almost twice as high in women than in men. So the risk is around 4.7% in men and around 8.5% in women, so experience depression in a given year. What's interesting is that those numbers are flipped when it comes to suicide. So the successful suicides, at least, are much higher in men than women. The average age for the onset of clinical depression is around 27 years old, although this might be getting earlier as people do more studies. And it's not just that it affects your mood. Depression really has some nasty effects on your body itself. Depressed patients are more likely to develop like coronary artery disease and diabetes. So it can definitely affect you in ways that just aren't associated with your brain or your mood. It's also responsible for about 70% of all the hospitalizations, psychiatric hospitalizations. So it's quite a serious drain on society and on, of course, individuals' psyche. And of those people who do commit suicide, which in the general population is less than 0.02% or something like that. So overall, there aren't too many suicides in a given year, but of the people who do commit suicide, about 60% of them were severely depressed. So depression is definitely a sad thing for our society. So I'll have pictures of bunnies interspersed in here. So here's from our front yard camera. Happy bunny, not a depressed bunny. All right. Diagnosis of major depressive disorders. How do we actually officially diagnose somebody with major depressive disorder? And then perhaps from that point give them some sort of treatment, maybe some sort of intervention therapy or a pharmacological treatment. So how do we actually diagnose this condition? So before going into the criteria for diagnosis, I just want to put this out there because we all are going to do this when we read these criteria, including me, is you're going to go ahead and see these criteria and self-diagnose or diagnose your friends and family or diagnose your enemies with the disorders in the DSM-5. It just is what we do. It's like if I told you don't think of a pink elephant, you're going to think of a pink elephant. We just can't help it. But even though I know we're going to do that, just take your own theories with a big grain of salt. I mean, none of us are professionals trained to diagnose people with mental disorders. I mean, I'm a trained psychologist, but really only qualified to diagnose rats. So whatever our diagnoses are, we can't necessarily take them too seriously. So that's just a caveat when we go through these DSM-5 criteria. Okay, let's go to the criteria. Diagnosing major depressive disorder. First, you have to have one of two symptoms that has to last for at least 2 weeks. One is that you have to have depressed mood most, if not nearly every day for 2 weeks, or you can just have this feeling of decreased interest or pleasure in anything. So you just don't get that same enjoyment out of riding your bike or running or hanging out with your friends. You just don't get any sense of pleasure from any of those events. All right, if one of those two criteria is met, then it goes to the next level where you have to meet 4 of the following symptoms or criteria. And these include significant weight change that include either loss or gain, a slowing down of your thinking and or your physical movements, like you're just moving slowly, you're thinking really slowly. Fatigue is another very common criterion. A general feeling of worthlessness or guilt, diminished ability to think or concentrate, or being indecisive. These are part of the cognitive effects of depression. And then a very common symptom of depression is these kind of self-thinking, or we'll call it recurrent thoughts, both just negative thoughts, either in this case of death or suicidal ideation without a plan. You might not be really planning it, but just thinking about it. So that's one of those 6 criteria. So of those 6 criteria, if you are diagnosed as having 4 of them or more, and you meet one of the previous criteria, you will likely be diagnosed with major depressive disorder. Now, that being said, if you do have it, there's a lot of variety in how individuals express it. for some people, like here are two examples of Jack and Jill. Okay, two individuals that would be clinically diagnosed with major depressive disorder. So let's say Jack is really antsy, can't sit still at all, but Jill, on the other hand, feels withdrawn, doesn't want to go out or do things anymore. Jack might like to also not do the same things he used to do anymore, but he, instead of Jill, has gained weight, whereas Jill might have lost weight. Jack might not be able to sleep at all, but Jill is staying in bed really late. Maybe Jack has thoughts about suicide, maybe even acted on that and wrote a note, but Jill doesn't have those thoughts necessarily, but she still can't concentrate, and she might just be having really slow thinking or slow movements as well. But both of them, because you can meet a mixture of the criteria, could be diagnosed with major depressive disorder. All right, with that, I will end part 1 with, he kind of looks like he's smiling with this particular javelina. All right.